Hey, welcome back to Not So Complicated, and today we are doing episode 14 of clinical case discussion. So here is a challenge for you. You have to diagnose this case. A 2-month-old male infant is brought to the emergency department by his parents due to episodes of turning blue while feeding and crying. His symptoms improve when he is placed in a knee chest position. On physical exam, he is cyanotic, and auscultation reveals a harsh systolic murmur at the left upper sternal border. A chest X-ray shows a boot-shaped heart, typical feature of tetralogy of Fallot, and echocardiography confirms the diagnosis, right? So which of the following best explains the underlying pathophysiology of this patient's condition? So all of these findings are very significant and very simultaneous to tetralogy of Fallot. So we have to understand what is the underlying pathophysiology. The options are defective endocardial cushion fusion, failure of neural crest cell migration leading to conotruncal septum malalignment, incomplete development of the atrial septum primum and secundum, abnormal migration of pulmonary venous tissue, defective closure of the interventricular membranous septum only. You can pause the video and do the diagnosis, and then we will talk about we will debunk each of these options, and we will talk about management and clinical features and pathophysiology in detail of the right answer, right? So here is it. Defective endocardial cushion fusion. This is actually seen in atrioventricular septal defects, which is common in Down syndrome, not in tetralogy of Fallot. The option B is failure of neural crest cell migration leading to conotruncal septum malalignment. This causes ventricular septal defects, right? So it is probably the right answer. And then incomplete development of the atrial septum primum and secundum, it will lead to atrial septal defects, obviously. And the classic feature of atrial septal defect is fixed split second heart sound, not the tet spells or cyanosis, right? The fourth option we have is abnormal migration of pulmonary venous tissue, that refers to total anomalous pulmonary venous return, TAPVR, where pulmonary veins drain into systemic venous circulation, right? So it is also a cyanotic heart disease like tetralogy of Fallot, but it is very unrelated, unlikely. The last option we have is defective closure of the interventricular membranous septum only. So this would cause an isolated VST, not the complete constellation as seen in TOF. So VST is a part of TOF, but not the root cause. The misaligned conotruncal septum is. So diagnosis is tetralogy of Fallot, and option B is the right answer. That is failure of neural crest cell migration leading to conotruncal septum malalignment. Let's talk how. So the mechanism of this lesion is that tetralogy of Fallot results from malalignment of the conotruncal, which is also called infundibular septum, which is derived from neural crest cells. So actually what happens is this septum divides the embryologic truncus arteriosus into the aorta and pulmonary artery, right? So if migration is faulty, the septum is displaced anteriorly and superiorly, causing 4 lesions. There is tetralogy, so 4 lesions. Pulmonary stenosis, not only pulmonary, it is actually right ventricular outflow tract obstruction. It can be infundibular obstruction, right? So overriding of aorta is another lesion. That is, it receives blood from the both ventricles, and ventricular septal defect due to failed closure of membranous septum. And also right ventricular hypertrophy, because there is pulmonary stenosis and there is more overload. I will tell you how to remember these 4 lesions, right? So in a upcoming time. So during crying or feeding, systemic vascular resistance drops. So it worsens right to left sound across VST, causing tet spells, acute hypoxia, and cyanosis. So in knee chest position, it increases systemic vascular resistance and thus reduces right to left shunting, improving symptoms. So this is the underlying reason why knee chest position improves the symptoms of tetralogy of Fallot. So here is the main thing. Normal heart is here, and then tetralogy of Fallot. How do you remember these 4 lesions? First of all, what happens is there is pulmonary stenosis. You have to remember like that. There is pulmonary stenosis. So the right ventricle has to pump the blood with more force to the lungs, right? So if there is more force required, the right ventricle should go in the hypertrophy region. So right ventricular hypertrophy appears. And also, this hypertrophy will lead to the overriding of aorta, right? Overriding of aorta, and the ventricular septal defect is already a classic feature of tetralogy of Fallot that you have to remember. So that is how you remember 4 lesions. And in the chest X-ray right here, you can see the boot-shaped heart, right? There is a boot-shaped heart. And how do you say that it is formed as a boot? So apex beat is actually moved upwards and laterally, and that is what it means having boot-shaped heart, right? So let's talk about this. This is the summary of this reason. So clinical features of tetralogy of Fallot, that is loud systolic murmur, that is already in clinical findings, right? Hypoxemic blood to organs and difficulty in breathing, is fatigability and fainting, that is also called syncope, and tetisbal, that is hypercyanotic, blue baby will be there, right? And then since there is lessened oxygen, right? So to carry the more oxygen, to make more oxygen, the kidney will sense the lessened oxygen and release EPO, that is erythropoietin, and that will lead to synthesis of more red blood cells, which is leading to polycythemia. That is also the classic feature in late presentation of tetralogy of Fallot, right? So it's morning, feed me, why is everyone sleeping? Why is that? Because it is very common in mornings, causing cerebral anoxia, right? And in knee chest position or a squatting position, I have already said why the symptoms improve in that region. So that is how we do. And the treatment is surgical repair, removal of right ventricular outflow obstruction, VSD closure, right? Reducing right to left shunt. So the management of this case is done by this. Immediate management is done by oxygen saturation, maintaining oxygen saturation almost greater than 92%, 95%, right? So the oxygen from pulmonary vasodilation, lessening pulmonary vascular resistance, and knee chest position, increased systemic vascular resistance, lessening right to left shunt, thus the symptoms improve, right? So also beta blockers like propranolol should be given to reduce right ventricular outflow obstruction, and IV fluids or morphine, sedation, decrease oxygen demand, and systemic venous return, right? So the definitive treatment of this lesion is that we have to do the surgical repair, usually done at 3 to 6 months of age, close VST with patch, and we have to relieve right ventricular outflow obstruction by, example, resecting in fundibular stenosis. So any stenosis should be resected. So that is how we completed our case. Subscribe for next our clinical pulse. Thank you for staying with me.